I am pleased to invite Professor Dilys Walker, who is a professor in obstetrics and gynecology and the Institute of the Global Health Sciences at the University of California, San Francisco, where she directs maternal newborn health research group. She has more than 20 years of global maternal newborn child health, family planning, reproductive health, implementation research experience, collaborating with partners in India, Kenya, Uganda, Rwanda, Malawi, Madagascar, Mexico. So I will invite her to come and give us a synthesis of the stakeholder sound bites. Professor Dilys.
Thank you so much, Dr. Pulang. And it is a real honor to be here and to be co-hosting today's webinar and the series that will come to follow. I'd just like to begin by thanking all of the speakers, including those who provided the sound bites in the video you just saw. And I'd like to remind you that due to time constraints, we were only able to select small portions of their insights, and these full recordings will be available on the ECSA website, and I urge you all to dive a little bit deeper into some of those comments. Before we turn to our panel discussion and open this up to your questions and answers, I'm going to provide just a couple, the three messages that I take away from those video recordings. And I think the first is that, not surprising, the task to improve quality is going to require a multi-sectorial effort. We can't forget things like employment, food security, education, if we're going to move the quality needle forward. I'm also remembering in the back of my mind the White Ribbon Alliance is what millions women's voices and what they want. And what that revealed was right up there with quality of care is care provided in a clean environment. And I think some of the comments reflected that. Also, I'm struck by the fact that respectful maternity care, person-centered care, women-centered care are clearly no longer concepts that are pushing for recognition. Women-centered care with kindness, dignity, and respect is something we understand, we can identify, we can measure it. It's the experience side that is beginning to be given equal weight to the provision side of the quality of care pathway. So we're all, and I can hear it in the voices, aware of what that is, but it's, again, back to the implementation problem of how. And this needs to keep providers, as well as the women and their families, right at the center of the quality improvement efforts. And finally, we need to keep efforts driven locally by communities, their priorities, and informed by their own data. As a regional body, this ECSA convening and others, this will be a real challenge that is critical to the success to keep things sufficiently local and relevant. So let me now turn to introducing our esteemed panel. I'm going to introduce each participant, and then I'll pose a question to each. Following this, we'll have an opportunity to begin a dialogue with your questions. I'd like to invite that you pose your questions in the chat feature on Zoom, and we will have Dr. Pulang following the initial round of questions to field those. So I'm going to begin with Dr. Jessica Nsungwa Sabiti, friend and colleague. She is commissioner in charge of child and newborn health, as well as chair of the Partnership for Maternal and Child Health Technical Cluster in Uganda. She was appointed as the vice president of the Uganda Pediatric Association and has been working in the ministry since the late 1990s, where she began as a senior medical officer. She spearheaded strategic planning in RMNCAH and led a team of experts in developing the RMNCAH sharpened plan and investment. She has been engaged in policy and implementation research and publications in the field of child health, newborn, health system strengthening, referral care systems, and community health workers, quality improvement, policy diffusion, among others. She was nominated as a Global MDG4 champion and also serves as board chair and member of a number of organizations. She obtained her MD from Makerere University and her PhD from the Karolinska University in Sweden. So Jessica, let me begin with you. I'll ask that when each of the panelists speak, they turn their camera on, and then when they're done, they can turn their camera and their audio off. So to begin with you, Jessica, it's pretty clear that as a policymaker, evidence isn't enough. And what we'd like to hear from you is, what is your take on what ministries need in order to change policies and drive that practice change? Jessica? Jessica, are you able to take off your mute and your camera?
Okay. Thank you very much, Delis.
Thank
you
you
for inviting me to share my opinion on this important point, topic, which builds evidence with policy. First of all, I'd like to begin by a small preamble, because we in the policy-making world view scientists or view science as that process which engages very busy minds, people with very strong opinions and views, and sometimes we find that we believe that maybe they are not so well linked to what we are thinking. And also the other way around, I think also scientists believe that policymakers are chasing reality and they're trying to get services to everybody, and they don't even want to have time to think about evidence. So there's always that discrepancy. And many times people ask a question: do policymakers ever use evidence? And if at all, how often is evidence used? I want to assure members today that actually the answer is yes. And actually this happens very many times. And I think the only difference is that it doesn't happen in a very linear process. It's not A to B and C. It's a cyclical process. Sometimes we move forward and we drop things and again we come back to them. But it's very important to know that actually you can document the process. But also I'd like to substantiate this point that although it's an affirmative, and I'm sure most of my presenters are wondering whether their evidence will be taken up, I want to substantiate this point that although we use evidence, it also depends a lot on a lot of ongoing local environmental issues. For example, we know that, for example, research only provides one evidence. There are a lot of things to do with who's on the policy table, who is on the dialogue process, and the timing of the evidence. We also know that different questions may raise different types of evidence, and sometimes researchers need to know the evidence we need for things like, can it work? And the evidence we need for things like, is it worth it? So sometimes we need evidence to be brought so close to our simple questions we raise. Sometimes scientists leave us to work out what the question is because they present so much information. And at the end of the day, when they tie down their evidence, we're struggling to read what they first said at the beginning. But also to tell you that sometimes also policy making may require other innovative information from other sectors. For example, when we're working on human vaccines, sometimes we're also looking at other animal issues. When we're looking at the girl child, for instance, issues of adolescent health, we're also looking at other sectors, gender, the law reform. So people who are doing evidence should actually understand that when we get to policy making, we have a convergence sometimes of sectoral views, and that is very important. And of course, the other most important issue is timeliness of the evidence. The reality is that policymakers are actually under pressure.
Jessica, I believe you were finishing up, but I think that was we've lost you, or you're finishing up. but I think we'll move us along just in the in interest of time. But clearly you present a very unique perspective of having really been wearing both hats of a policymaker and a researcher. I'm going to turn now to Dr. Daniel Okello. He is the acting head for the Public Health and Environment Directorate at the Kampala Capital City Authority. This directorate has the mandate to facilitate and provide supporting and ensuring health and productivity of citizens and a clean, habitable and sustainable community for the city. Dr. Daniel Okello, we'd like to hear, we understand you have been deeply involved in the COVID response in Kampala, and we'd like to hear very briefly about the impacts of COVID on health service delivery in Kampala. Can you tell us how you are addressing the situation and what evidence, data you have used or need to make those decisions? And if you could, again, turn your camera and audio on, that would be greatly appreciated. Thank you.
Right. Thank you very much. And I'll give a perspective from the city, but since I also sit on the National Scientific Committee, Advisory Committee for COVID, I'll also try to give an idea of what has happened in the country. One of the initial effects of COVID was the measures that were put in place by various countries, and the one that is easily recognizable is the lockdown. So with the lockdown, the initial effects of the lockdown was more or less services came to a stop. Although we know that exemptions were given to health workers, but by the nature of COVID not being at par with crowding, the services that were initially most affected were the primary healthcare services. These are the outreach services. Much as facilities were open and you'd walk into a static facility, at that point, we shut down immunization services, we shut down HIV counseling and testing, and we also had a challenge for people being able to access services like ART, TB services, being able to have their chemotherapy done, and also dialysis. So those were the services which are affected most. And the other thing we noted as through service delivery that there was a redistribution of patients. A redistribution occurred from the private facilities to the public facilities. With the lockdown occurring, public transport came to a standstill. Private transport was limited to a few, and that meant that most of the private facilities could not function to full capacity. The effect of that was that access was reduced to those who needed care, and that meant that the public facilities needed to take the load of patients. So you could also see that very clearly from our data that was being presented. But we also thought that when you look at redistribution, could have been due to the economics, whereby people were out of work. They could no longer be able to afford to pay for private facilities, but needed to access facilities from public facilities which offer services at no cost. So that could have been one of the reasons that people moved again from private to public. The other was which is hidden, but when you dig deep, you notice is about the HR, the human resources for health. When COVID did come earlier on, we needed to redistribute health workers because especially when you're setting up the care and treatment centers, a good number of health workers were pulled from the general pool and focused onto COVID care, and that meant that services in other areas suffered. A case in point was when you needed to take off a sample, oral or oropharyngeal or nasal. The initial phase is that it had to be done by a lab professional, but we didn't have those many lab professionals to take off samples. And the next question, probably if I answer this, what did we do? We then needed to task shift. We realized that this was not something that strictly needed to be done by a lab professional. And we just trained even surveillance officers to be able to do that, but we also trained nurses to be able to do that. And that freed the health workers then to be able to do the critical services, the continuity of service to be in place. So from then, to me, the effects, just the three: the primary healthcare services, the adherence to treatment, especially in chronic conditions like TB, ART, dialysis, chemotherapy. Those were initially disrupted. But what we did for those who needed chronic care, in Kampala, we have the public motorcycles that people call border borders. So we had arrangements, we had a partnership with the border industry. And what we did through this is that we had set up a call center. So we'd get phone numbers of the people who are due for appointments on that day, call them, and they would be able to station themselves at a particular point, give their supplies to the border riders, and they would make rounds and do drop-offs to people. So this helped to make sure that people were able to get their meds, but also adhere to their medicines. As I said again, as for the health workers, as for the primary healthcare services, the majority that were hit were private facilities. So we partnered with World Vision, and we supported these facilities to transport some of the health workers from home to the facilities and back, because that's what some of them needed, so that we could be able to kickstart the static immunization facilities. Others, like reproductive health and also being able to give reproductive health products, we partnered with supermarkets, and some of those products that can be self-administered, we dropped them at, we looked at drop-off points at supermarkets where people would come and pick up some of these reproductive health products. So we needed to innovate to see how we can be able to mitigate the impacts. Not that we'll cancel them out completely, but really to be able to mitigate. So very quickly, in a very quick summary, I can say those are the impacts, those are some of the innovations that we had. Thank you.
Thank you very much, Dr. Okello. Clearly, you and your team have been innovating at a rapid rate. I'm going to move on now to Dr. Warfa Osman and Change Countries. Dr. Warfa is the director of the Directorate of Health Sector Partnership Coordination and Intergovernmental Relations at the Ministry of Health in Kenya. And he's the immediate former head of the National Child and Adolescent Health Unit, Division of Family Health, also in the ministry. Dr. Warfa, I'm going to ask you whether this new position of yours as the Director of Health Sector Coordination and Intergovernmental Affairs, can you tell us a little bit about if and what the RMNCAH priorities are and how you are linking those together? Thank you.
Thank you very much, Dr. Dillis. Can you hear me?
Yes, we can. Thank you. If you are able to turn your camera on, that would be great. Otherwise, yes, we can hear you.
I want to apologize. My camera is not working. The IT system were also unable to fix it. We actually don't know what has happened. So, but I can continue.
Please do. Thank you.
First of all, I want to thank the distinguished members for having joined this very, very great important discussion to advance reproductive, maternal, newborn, child, and adolescent health. For me, it's a great pleasure to be here. And on the same breath, I want to sincerely thank the organizers of this forum. Coming back to your question, Dr. Dillis, remember, in just to bring you on speed, in the year 2010, there was some constitutional changes in Kenya, which now divided the country into various levels of government. So there's one national government, and the 47 county governments. The 47 county governments are in the regions. So we kind of say we have like 48 governments. And the healthcare, through the constitution, healthcare now was devolved to the 47 counties. But there was some responsibility which was left at the national government, that is the National Minister of Health. And the National Minister of Health was given the task for policy directions, capacity building, and technical assistance to the counties. And the counties were given the task or the functions to actually provide healthcare services, all the way from the hospitals to the health centers, dispensaries, to the community level. So what we do in this directorate, for me as the in charge, is like we coordinate now the intergovernmental health activities between the national and the county government. And also we also coordinate health activities between the partners and the two levels of government. So this actually has given us an edge as a directorate where the national priorities and the county priorities, and also what I can say the partners' priorities, is driven by this directorate. As we drive now the priorities, we table priorities for reproductive, maternal, newborn, child, and adolescent health activities for the country. What happened is just early this year, around January, February, there's a document which I can say, I wish my camera was on, I will have shown you the document. It's a policy guideline which has brought all the health sectors together under the partnership and a coordination framework. It's called Health Sector Partnership and Coordination Framework. It's a key document to guide the implementation of various health activities. But for us, where we sit as a directorate, we have prioritized reproductive, maternal, newborn, child, adolescent health issues, and also look for resources to invest towards improving the health sector. And more so during this COVID period, where we say for every newborn, every child, and every mother. I will stop at that. And I want to say thank you so much.
Thank you so very much, Dr. Warfa. And I'm certain that many of the listeners can appreciate the importance of the coordination between the regional, county, and the federal, and how critical that is, particularly in a time of crisis like that we're facing with COVID. And to our final panelist, and I'm hoping we'll still have a little bit of time for a second round, I'm going to invite Hester Nyasulu, who is the Executive Director of the White Ribbon Alliance in Malawi. This is an organization advancing the prevention of women from dying needlessly in childbirth. He has over 15 years experience in reproductive, maternal, newborn, child, adolescent health advocacy and programming. So, Mr. Nyasulu, we've heard a lot from researchers, policymakers, implementers throughout this event. Can you tell us from an advocacy perspective, how can we better engage advocates in our efforts to use evidence to improve policy programs? Pass it to you, and if you could turn your camera on, that would be great.
Thank you so much. The host will need to help me to open up the video. Okay, right. So, very good question, Dr. Walker. I think what we need to do is to help advocates realize the noble task that they have to bring together the two different worlds that we have heard here, the world of researchers and the world of policymakers. These two, for them to be connected, advocates can play a very big role to bring what is there on the ground in terms of research. I hope in analyzing that the information and then taking that to policymakers to influence change. So that's the role that the advocates have. And the second part is also to help the advocates on their role on networking, because as we've heard, most of the issues that we deal with are multisectoral. So our advocates also need to have the capacity to bring different players together. And then once they bring them, help to coordinate in building a case towards policy change. And also lastly, I was also bringing in the fact that our advocates need to be assisted on how to analyze information. So, you know, you cannot be a jack of all trades. So most of our advocates have got some areas where they're not so strong. And this is an area where our advocates need to be supported to analyze information and how to bring it towards the policymakers and bring change. And Dr. Walker, you just alluded to the study that we did, the campaign on what women want, where we interviewed over 1.2 million women and girls globally. What came out is that what we are seeing now, when we use the results that we got on their needs for respect, needs for privacy and confidentiality, need for good water and sanitary facilities, we are seeing a lot of response from policymakers, and already we're driving a lot of changes in the programming, but also in how we shape our policies in Malawi, but also in the countries that we're working. So I think that's an area that we need to motivate the advocates to understand, and that will build their confidence to push in using the evidence. Thank you so much.
Thank you so much. And I think you're absolutely right. It's that none of us can continue to work in our silos, and we all need to support each other. And as Dr. Claire said, collaborate and discuss and disseminate. Thank you very much for this first round of questions. I would welcome anyone to post a question in the chat. We do have a couple of additional questions. I'm going to turn the microphone back to Dr. Puleng to facilitate the remainder of the panel discussion, and then I'll come back and tell you about our next series, or the other sessions in the series. Dr. Puleng?
Thank you, Dr. Walker. So I will now ask our panelists a second round of questions, and I will start with Dr. Sabiti. And the question is, how are you approaching respectful maternity care, woman-centered care, people-centered maternity care? Is it integrated into service delivery, or is it separate?
Thank you very much, and apologies for the last disconnection. Respectful maternity care is one of our key areas we are introducing in our package of services under the quality of care work we have just, we're trying to scale up in the country. We did standardize and adopt the WHO quality of care standards, which were launched in 2016. And the first thing we did was to try and understand what respectful maternal care would be. We had some challenges because some of the things we thought were very obvious were not very obvious. For example, we had issues like the way parents and mothers and midwives communicate to mothers when they're delivering. Some of the issues we actually thought would actually serve as views for respectful care. We were very surprised because people did not think they were very unrespectful. Things like forcing mothers, shouting at mothers to push, sometimes were seen as mechanisms of saving the baby. So we did a very good, very rapid formative study And we combined this with a satisfaction study, and we're able to design some few issues which we have now been able to incorporate in our service delivery standards. We are now at a point of trying to see how we measure them, especially trying to use more rapid methods we can link with our routine supervision tools, in addition to having exit interviews. So for the first time this year, we've been able to identify some indicators, and we're now at a stage of negotiating with the health information system to pick up some of them. And also we are also negotiating, we have a program for performance-based financing to see whether some of these indicators can actually be included to qualify the coverage data we have on maternal services, especially delivery in the health facility. So that we were beginning to pick it up. It's a very slow process. It's a very consultative process. Sometimes we have had to negotiate with the providers and the mothers to see whether they can take up some of our ideas as we continue refining them.
Thank you very much, Dr. Sabiti. It looks like Uganda is way advanced in addressing respect for mothers. I will ask the second question to White Ribbon Alliance Director. And the question is, White Ribbon Alliance has been a leader in advancing respectful maternity care through defining it and bringing awareness to the problem. Now that it's on people's radar, what is your advocacy strategy to continue to advance respectful maternity care? And what does success look like?
Thank you so much. I think the key thing now that we have seen, we have to define respectful maternity care in the definition of women themselves. And that's an area that as White Ribbon Alliance, we have managed to achieve. The next thing I think is now to also help the women to realize the power that they have to drive this agenda. So this agenda doesn't need to just be driven by advocates or programmers. We need to let the women and girls themselves to drive this agenda. And we can only do that not by empowering them, but to help them to realize the power that they have, the rights that they have, for them to request and ask or demand, using that word, demand for their right and get the respect that they deserve. So that's the another angle that we're looking at, and that's where we can draw a lot of success. Yeah, that's the opinion that we have as White Ribbon Alliance. Thank you.
Thank you very much. I think that focus does really empower women and make them aware of their rights and what power they possess to make positive changes in their lives. Thank you so much. My next question is to Dr. Okello. Can you share an example of a successful evidence to policy pathway? How you used evidence to drive a policy practice change?
Thank you for that. I will give an example that is in the sanitation sector. My directorate is Public Health and Sanitation. In 2017, we did a sanitation census in Kampala. It was among the few that has been done in an African city. And that was to find out the state of sanitation. Out of that census, what came out clearly was that we had an issue with fecal sludge management and the way the industry was organized, because only 8% of Kampala is on the sewer line. The other 92% on site. So we either have septic tanks actually on our site. So out of that, we came up with a law. Okay, we pushed with evidence that we needed a law to regulate how fecal sludge management is done in the city, from the industry to the people and what the policymakers need to do. You'll excuse me, there's some background noise because we are in an election period in Uganda. So that's why you hear that background noise. So that, from that process, we came up with a city level ordinance, which we call the fecal sludge ordinance. It is the first specific law like that in the country. And at subnational level, that also led to us having the Kampala financing strategy. So it started from data, now we have gone to the financing strategy for the city. So again, thank you. That's the example that I can be able to give.
Thank you very much. I realize that you have also touched on financing, just like the previous speaker alluded to performance-based financing, yes. So my last question will be to Dr. Osman, and it is, has anything you heard so far today surprised you, piqued your interest, or is something where you would like to offer a different opinion?
Okay, thank you very much. First of all, I said coming together in this kind of forums and discussions to take forward the health of newborn children, mothers, and adolescents is something to be congratulated to all the members who are present and others who are not able to join us. For me, I am truly amazed by the discussions which has taken place today. I'm a bit taken back or surprised. The passion and actually the commitment by various organizations, call it like-minded organizations, who are all ready to take forward a productive maternal, newborn, child, adolescent health. The passion, the commitment is truly palpable. From our end in Kenya, as I said, implementing the document which we developed the other day, which was the Health Sector Partnership and Coordination Framework. It was intended to bring both the governments and the development partners, implementing partners, to align their resources for the health sector. And borrowing from the discussions which I've seen today, I think we are a step ahead. That these discussions we have today actually will inform us even to drive or to implement further this partnership framework. What I wanted to add is the discussions on evidence use or policy direction, which has been discussed here. Just to give you an example, we have closely worked with Dr. Dillis and her team in a project called Preterm Birth Initiative, where the data which was generated from the counties actually informed us to have some policy directions, particularly for the newborn, where the data which came from the field showed that indeed newborns are dying because of prematurity and the likes. So Kenya now brought in now from that evidence, brought in scaling up of kangaroo mother care in all facilities in the country. So if you look at the discussions which I've had today, I truly believe we can move forward the agenda for newborn, children, adolescents, and mothers. I think I will stop at that unless there are questions after this. Thank you so much.
Thank you, Dr. Osman.